Well, hello. It is the top of the hour, so let's go ahead and get started. Welcome to our webinar. My name is Emily Eberly, and I will be your behind-the-scenes technical host. And on behalf of Teleflex, I want to thank you for joining us for our Clinical Foundations webinar series, where we are focusing on healthcare worker safety. And now, I'd like to introduce you to Jerry Iserman, who is your moderator for today's live broadcast. Jerry, welcome. Are you ready to get started?
Thank you, Emily. Yes, I am. And hello, everyone. Thank you so much for taking time out of your day or evening or afternoon to join us for today's webinar, which is titled Waste Anesthetic Gases Among Healthcare Workers, a review of the risks and prevention strategies in the PACU. And today, speaking on this very important topic are two leading experts, Dr. James McLaughlin and Dr. John Menning. Dr. McLaughlin is an Associate Professor of Health Sciences in the College of Health and Human Sciences at Purdue University. His extensive research specializes in ergonomics, exposure assessment, focusing on video exposure monitoring, occupational hygiene, engineering controls, and epidemiology. He is the Director of the Graduate Program in Occupational and Environmental Sciences and Co-Director of the Center for Virtual Reality of Healthcare Center Design at Purdue University. Dr. Menning is currently in private practice at Indiana Oral and Maxillofacial Surgery Associates. He's published extensively in peer-reviewed journals on a range of topics relating to oral surgery and scavenging of anesthesia gases. He is on the board of the Indiana Oral and Maxillofacial Surgery Associates, an assistant clinical professor at the Indiana University School of Dentistry. A true inventor, Dr. Menning has several patents that enhance patient and clinician safety during and post-anesthesia. Our speakers today have disclosed the following. Dr. John Menning has received honorarium and expenses for his presentation today. He has executed a royalty-bearing license of his patent rights for the design of the scavenging mask IsoGuard to Teleflex and is a consultant with Teleflex. Dr. James McLaughlin has received honorarium and expenses for his presentation today and has disclosed no conflicts of interest in the development of the webinar. No off-label use of products will be discussed in this webinar, and the presentation is sponsored and funded by Teleflex. Of course, this education activity is approved for continuing education credits, both for nursing and respiratory therapists. The important thing for you to remember is at the end of the webinar, you can obtain those continuing education credits by logging on to the address you see here, www.saxtesting.com/CF. Just complete the post-test and evaluation form, and upon successful submission, you'll be able to print your certificate of completion. And now, without further ado, I would like to turn the webinar over to our first speaker, Dr. James McLaughlin, who will start the presentation by a quick overview of the learning objectives. Dr. McLaughlin?
Thank you, Jerry, for your very kind introduction. The learning objectives are very straightforward. We have a very rich hour of information to pass forward to you. We want to discuss waste anesthetic gas and its impact on healthcare providers and understand the existing guidelines and impact on the clinical practice and provider safety. Examine the post-anesthetic anesthesia care unit environment where we have waste anesthetic gas risk for the PACU nurses, understand the latest research in the development and presence of waste anesthetic gases in the PACU, and then finally to gain an understanding of a new solution to reduce waste anesthetic gas exposures in the PACU. This last talking point for learning objectives is very important, and I want to say it at the front end where it's critical, and that is that I've been doing research in this area for almost 40 years now, and I've only come across a handful of cases where I can demonstrate we have a solution to a problem that hasn't been fully understood and fully recognized, and I believe with all the experience experience that I have as a researcher, that the idea of coming up with a solution that's so far out ahead of people really recognizing that the PACU is an exposure issue in terms of waste anesthetic gases, that to me, this is really the take-home message of the entire webinar. So what, go back up. So what is a waste anesthetic gas? We look at this as in terms of what it surrounds the patient in its atmosphere. It comes in leaks in equipment and enclosed systems, for example, compressed gas tanks. It's in the breathing circuit and scavenging systems. It's being picked up from the patient. Also, it's being escaping from open systems such as dental practices. For example, if you have fatigued O-rings for connectors, the rebreathing bags and so on can become fatigued and cracked, and exposure issues there. In the PACU, this is where it's totally unique, and we're looking at patient exhalation. And one of the things that in my experience has been, it's very counterintuitive, having a exposure and background in engineering and in public health, is that you're always looking for sources such as the tank itself in which the gas is being delivered, and you're never thinking that the patient is a significant exposure source. I'm here to tell you that the patient is a significant exposure source for waste anesthetic gases in the post-anesthesia care unit. So WAG exposure then, especially secondhand exposure for healthcare personnel. In other words, what's coming from the patient and the proximity of the healthcare personnel, in particular the nurses and working with patients, that close proximity can result in exposure issue. So who's exposed to waste anesthetic gases? The obvious personnel exposed would be in the operating room, anesthesiologists and nurse anesthetists, of course the surgeons in the room, room nurses and technicians. In dental practices, obviously the dentists and dental assistants, and in some cases dental hygienists can be exposed. And then in particular, and we have this in bold, the post-anesthesia care unit nurses are exposed in particular because of their close proximity in working with patients. One of the things that's very important here is what are the effects for high exposures and low exposures. And when we talk about high exposures, we're really talking about, something that is significant and beyond the recommended exposure limits as set by NIOSH and the American Conference of Governmental and Industrial Hygienists. And that is that we're looking at fatigue and nausea and headaches and difficulties with judgment and coordination. Liver and kidney disease come into play. Long-term low-dose effects have been linked to reproductive effects in exposed women and men in these environments, and that means the waste anesthetic gases are a teratogen, which can get down to the genetic level of exposure. This often results in miscarriages and birth defects in offspring, such as cleft palates and heart murmurs and so on. There is also genetic damage that occurs, and only in the past few years we've had the ability to really get right down to the DNA and look at its impact on the DNA. And then cancer has been reported. Dr. Manning will talk about a review of the literature in which he will take us right from where the government has left off to right where we are today, with many of the new technologies being lent to this to show us the impact for waste anesthetic gases. By the way, the publication that you see in the right-hand margin of this slide is from the federal government. I had a hand in helping develop it. We're looking at occupational hazards in hospitals. This gives you a very nice overview of the concern for waste anesthetic gases, particular to this talk today. Operating room exposure to waste anesthetic gases, it's been well recognized and studied problem over the years, and there are 3 points of control. One is facility design and engineering, administrative practices and procedures. This includes best work practices, and finally maintenance and proper use of the equipment. Remember that all equipment does have a life cycle to it. It does need to be maintained. You just don't plug it in and forget about it. You have to maintain it, and I will talk about that in a few later slides. So when we look at the dental exposure to waste anesthetic gases, to which I've been conducting research for nearly 3 decades now, associated with dental operatories, we know that they can expose, in particular, because of patient mouth breathing. A particular system was developed by Dr. Manning called the Safe Sedate Mask, and the idea was to control patient mouth breathing, but more important to this was to the delivery of the gas directly to the patient and try to minimize any leakage around the mask so that the dentist and dental assistant would not be exposed. We did a study on this, and it performed very, very well, and it significantly controlled waste anesthetic gases in controlled environments for the studies that we did at Purdue University. With the PACU, we've also done some studies there, and I'll get into that a little bit later, but I want to give an overview of here is that unlike the dental operatories, PACU personnel are exposed to WAGs from patients and not the equipment itself. So in the dental operatory, you're concerned about the delivery of the hookups from the delivery systems of the gas to the patient and from the patient outside the room through vacuum systems. Here, the primary source is the patient themselves. So the belief that patients are not outgassing or exhaling waste anesthetic gases once they leave the operating room at significant levels is disputed in the study that we did. Exhaled waste anesthetic gases, it's invisible to the caregivers. You can't really taste it or smell it unless you have it in high concentrations. And the claims that it's related to the newer inhaled anesthetic agents such as acetylfluorine, the desflurane, and so on, these have a higher toxicologic impact on the caregivers and is of concern. And then the claims related to looking at dosimeters and saying dosimeters are a primary source of evaluation for exposure are debunked. And I put my reputation on the line with that. They are a screening tool, not a primary tool. Often when you look at the literature for use of dosimeters, almost across the board, that dosimeter levels usually report lower concentrations compared to gold standards in using real-time instruments such as a infrared spectrophotometer. And then finally, we're looking at air changes and so on in the PACU environment. Because it hasn't been well understood that patients can be a significant source of exposure, we'll see that air changes in the PACU are much less than what we'd find in the operating rooms. So OSHA guidelines to manage waste anesthetic gas risk in the PACU. We're going to just expand on this a little bit with facility design and engineering. Note that in operating rooms there we have 15 air changes in an operating room. So think of a large cube and turning over that air in that room 15 times, and mixed in it is 3 fresh air changes. In other words, 100% outside air with absolutely no contamination of inside air sources whatsoever. In the PACU, it's less than half of that. Only 6 air changes are recommended with 2 fresh air changes per hour. And so one of the issues that we want to bring to the table is that are we getting adequate air changes in the PACU based on information that we're going to talk about today, or should we look at improving that ventilation in the PACU, especially and also with increases in fresh air into the operating room? And then also isolated fresh air intakes are very important, meaning that it's not a good idea, and I've seen it several times where you have exhaust air being set up right next where the intake air is set up, and what happens is you have a short-circuiting of the airflow into that environment. Next is administrative, with work practices and training and hazard communications all come into play, but more important is best work practices getting in there, and because the nurses have to be close to the patients and bringing them back to baseline and so on after surgery, there is that element that has to come into play. So that's part of the hazard communication and training process. And then there are professional organizations that have released guidelines to their organization members to be able to control exposure to that. Both of the associations here are on record for saying be careful about exposure to waste anesthetic gases. And then finally, maintenance and proper use of equipment. Very important when the equipment is installed, it's installed properly, it's calibrated, it's maintained, it's understood that they have life cycles to them, and you do periodic leak checks. My recommendation is these leak checks should be done at least twice a year, preferably once a quarter, to make sure that everything is working as they should. So at the bottom line right here, for post-anesthetic care units, it becomes difficult to control health care workers' exposure to WAGs because of the exposure source, and we think we have a solution toward that end. So NIOSH established recommended exposure limits. These are called RELs for waste anesthetic gases. It's listed as 2 parts per million as a ceiling concentration for halogenated gases. And as many of you know, sevoflurane is the anesthetic of choice. Desflurane is also used in that, and it's not to exceed that concentration over a 1-hour period. The next is nitrous oxide. Nitrous oxide is still actively used in many operating rooms, but its use in recent years has decreased in favor of the sevoflurane, desflurane, and the halogenated compounds. But you can see this also has a fairly low limit of 25 parts per million. When you look at sevo, a full order of magnitude less, it's a major concern. But note that with the nitrous oxide, it's during the time of administration. So from the time the patient's wheeled into the PACU to the time they leave the PACU, usually about an hour or less, is the time that should be controlled. They evaluate all available medical and biological, chemical, and trade and other information relevant to the hazard, including looking at the halogenated compounds and studying them. But the problem is that some of the material is a bit dated. The reference that I pointed to a little bit earlier is more than 10 years old. NIOSH needs to update the literature in this particular area to really study and actively look at it. And as I mentioned, part of the problem is that it has not been fully vetted that the PACUs are an exposure issue, and that needs to be brought to the government's attention. So the bottom line, though, is that NIOSH assumes a very practical approach, I think a reasonable approach, and that is that all trace gases of waste anesthetics should be kept to their lowest practical level. So exposing what's called the invisible risk, which I think is a great tagline for looking at waste anesthetic gases. As I mentioned earlier, you can't see the gases with the naked eye. You can't smell the gases. You can't taste the gases. And as a result of that, if what you can't see, what you can't taste, what you can't smell, there's a sense that it's not there. Well, we use some techniques to actually help you visualize that and show you that it is there, and it's there in significant amounts. So there are 2 systems that are used. One, we use an infrared camera system that has a lens on it that is tuned into helping us see waste anesthetic gases. In particular, what we focused on here was nitrous oxide, because there's been a couple of decades work in this area to which I helped develop. We can visualize it. And also we can see the heat signatures as they're coming off from the patient in terms of what that profile is it going directly into the breathing zones of the nurses and so on. The second, more important one is this Moran Sapphire Analyzer, which is an infrared spectrophotometer. This helps us quantify the concentration of the gas coming off in parts per million resolution. So as you recall, we're looking at sevoflurane at 2 parts per million, nitrous oxide at 25 parts per million. When in combination, actually the halogenate compounds are even forced to a lower recommended exposure limit of 0.5 parts per million. So I just want to show you a quick image of this before I turn this over to Dr. Manning. And basically it shows you a background of a candidate that is being monitored with infrared thermography right here, and you can see right here the nitrous oxide coming from the patient's mouth right there and from the nose coming out. Notice the close proximity of the nurse tending to the patient. It's just one of the things I absolutely love about the PACU nurse is their passion for what they do, but they're right in the firing line when you're looking at how the waste anesthetic gas is now coming from the patient and directly into the breathing zone of the nurse. So at this time, what I'm going to do is turn this over to Dr. Manning, who's going to briefly review the literature for you. As we mentioned, we scan the literature every week to see if there's anything new that's coming out and so on. And to me, this is the second tag point, and that is there information out there that points to this as it being a significant hazard? Dr. Manning.
Thank you, Jim, and thank you, Jerry, and thank you all of us and thank you all for joining us. I'm especially glad to see so many respiratory therapists that signed on, as I think we're learning that when we deliver these anesthetic gases, we're dumping them into a big reservoir of the lung, and they've got to come back out, and you certainly are all also in the line of fire, and so I'm glad you're going to be gaining some of this knowledge base. But if we look at the significant research over the last 50 years, you basically want to consider that there are certain societies and national organizations and then the world literature that have tried to put out a lot of information in regards to what is going on in these arenas that Jim has just talked about. And if we look at the one common theme, and I think this is what we're going to try to talk about extensively, is that whatever kind of study you want to call it, an observational, a prospective, or retrospective, even with carefully designed research protocols, everything is always pointing that we should try to keep any exposure to waste or trace gas kept to the lowest practical level. And as we'll talk about here, the literature supports scavenging systems, and that's what we want to try to illustrate to you as we go through things here. So if we look at the literature over these last 50 years, try to get my pointer to work here. Starting back in 1967, you had literature coming out of Russia. These were observational reports where the female anesthetists were experiencing significant number of miscarriages with their pregnancies. And a lot of this information then started to circulate into the United States, and NIOSH put their first bulletin together in 1977. And this was basically to bring awareness to the fact that scavenging systems should be involved in the operating room. If we move forward on our timeline here, then you get into the organizations that we talked about. You had Cohen discussing things in the ADA journal, Buring reviewing the literature for the ASA, you had Dr. Rowland in the New England Journal of Medicine, and all of these are referenced here for you to do a more in-depth review. But most of these were then all retrospective studies and doing evaluations of large samples. And this was then looked at by NIOSH when they did their new update in 1994. Dr. McLaughlin was a vital part of this publication in 1994, and basically they put forth the different ways to try to capture these gases and try to minimize exposure, and those are well outlined in that publication. In 1996, the American Society of Perianesthesia Nurses dedicated an entire journal to this subject matter, and their position statement was that all necessary and protective engineering controls, technologies, work practices, and personal protective equipment be utilized in this environment. That there were respiratory pathogens, bloodborne pathogens, waste anesthetic gases, all being documented in this arena, and they encouraged further research to look at this. In 1998, one of the authors in this journal, Dr. Bagwell, along with Dr. Sessler, did look at the PACU in depth, and they were making measurements with dosimetry badges, and they found that in 68% of the patients that came into the PACU, 35% of the time that they were there, their levels were above these recommended exposure limits that NIOSH had published, whether it was with isoflurane, desflurane, or nitrous oxide. Sevoflurane was just breaking onto the scene at this time, so it wasn't really one of the main anesthetic agents that could be studied. So if we move forward a little bit around the same timeline, we get into an era where we're looking now at molecular technology and molecular studies. We're looking at what kind of effects do certain chemicals maybe that we breathe or that we're exposed to, what do they do to our DNA? And there was a very good article that is referenced here, number 2, that was published in 2008 that talked about the chromosomal aberrations in lymphocytes as a predictor of cancer risk. And they looked at 22,000 subjects in 11 different countries and found that there could be correlations between these kind of molecular changes. So with that background, as we move forward on our timeline, we then see that studies in 1999, in 2001, and in 2005 started using this kind of technology to compare individuals that were in, say, an exposure environment, such as an OR, and if it was an operating room that didn't have good scavenging system versus other personnel in other areas of a hospital where they were not exposed to these areas, and they were finding these molecular changes occurring in these individuals' DNAs. And in Dr. Wiesner's article in 2001, they even went so far as to try to look at these levels and compare them to the NIOSH recommended exposure levels and whether these changes occurred if you were above or below the levels. And they found that exposures were present when you were above the limit, but could be controlled when you were below the NIOSH levels. So I encourage you to look at these articles. 2002, Dina Krzynicek in Baltimore looked at the PACU environment in regards to whether the nurses were truly being exposed, like Dr. Sessler and Bagwell showed in 1998, and how these situations were occurring. Nurses were breathing into the breathing zone, and they even made measurements in regards to the PACU nurses and their own breath. A lot of this then came forward again with a NIOSH update in 2007. They called for an examination of the situation, and they wanted to know what the latest research was from the different organizations that we talked about. As a result of this, there were 4 bullet points that NIOSH talked about. Number 1, we need to be more aware of this situation from waste anesthetic gases and possible health effects. We need to describe how workers are being exposed. They wanted to see and recommend work practices to reduce these exposures, and then to identify methods to minimize leakage of anesthetic gases into the work environment. As Jim pointed out earlier, if you can smell a particular anesthetic agent, and most of the time you can't, nitrous you cannot smell, but certain agents are detectable by odor, that even if the gas is 125 times the NIOSH recommended exposure level, only 50% of the general population can be able to detect it. So if you can smell this gas, you're hundreds of times above these recommended levels. So what's happened over the last 6 to 8 years? Well, we've started to see now a couple of very, very nice reviews of the subject matter from 2008 and 2011, where these researchers took over 200 abstracts on this subject matter, boiled it down and looked at 58 articles, and then made recommendations about what the literature was telling us. Bottom line, that we need to scavenge gases as much as possible, because there are definite correlations to health concerns that the literature is showing us. It's very difficult to pinpoint what exactly is going on because there's so many confounding variables that we all have, whether it's certain individuals may be smokers, what environment they're working on. But in reviewing these 58 articles, they found that scavenging was an important point that needed to be followed through with. We also started seeing from Dr. Sun in 2010 that there were concerns from anesthesia being given to small children, and this led to the development of smart tots in 2012. Their concerns are dealing primarily with the neurobehavioral consequences of anesthesia to children under the age of 3, and what effect anesthetic agents may be causing on brain development and neurocognitive problems. There was another excellent review in MUSAC in which they basically took waste anesthetic agents and combined them with anti-neoplastic agents and formaldehyde to try to look at some of these chromosomal changes. So you can pull that article. And then most recently in 2013 and 14, once again, a very good article looking at individuals that are dealing with this environment in the anesthesia arena and pulling their blood over different time frames over a 2-year period and comparing them to individuals that are not exposed. A lot of this was then kind of summarized in 2014 by the FDA, pulling a scientific board to look at this literature, particularly in regards to the smart tot situation, and the ASA and the pediatric anesthesia societies are all very active at looking at this research, and it's ongoing with studies called the PANDA Symposium that Dr. Sun is involved with. So it is important from this literature to recognize 3 main things. 1, the definite health concerns and genotoxic effects are present in unscavenged environments. That's the PACU. It's unscavenged. More research is needed on the effects of anesthetic exposure in the human brain development. And minimizing the exposure to waste anesthetic gases is the utmost importance and is stated in all of these articles and by every organization that has looked at this subject. So what is the main difference between an OR or a dental clinic? Well, the main thing, the most important thing to take home is the changes in the percentages. Anesthesia machines look at percent of what you give, such as sevoflurane, which is given in maybe 2% sevoflurane. That represents over 2,000 parts per million. I'm sorry, 20,000 parts per million. So when a patient starts to spontaneously breathe at, say, 0.3%, that's 3,000 parts per million, and that's when the patient is usually extubated. So they still have a very high level of parts per million, and that's what NIOSH is concerned about. And that is the main difference between what's going on in the OR and what comes into the PACU. It's no longer a percentage formula, it's a parts per million situation. So in the PACU, the main potential risk is basically that in the OR, we're dealing with percentages. An anesthesiologist will maybe make a statement that at 0.1% or 0%, there is no longer any gas available. But we will show you later on that the gases are there, both through visual and documented Moran readings. So parts per million are what are occurring in the PACU. The patient is the main source of this contamination. The nurses are always in very close proximity to this patient as they're delivering care usually right over the head of the patient. Room air exchanges will not address this kind of occupational exposure problem, and most nurses are not even aware of this situation, or respiratory therapists, since they're also involved in this facial close proximity. So once again, reducing the exposure in the PACU is mainly through reducing the source. And this is just showing some of the outline of what we're going to be talking here in regards to our study. The mask is in place, and that's a Moran wand making measurements. So a lot of this is documented in a Clinical Foundations publication that Dr. McLaughlin and I worked on, and then there are certain panel questions that are very good that Dr. McLaughlin, Dr. David Farr, and Joni Brady, who's with the PERIANESTHESIA Nurses Association, all answered specific questions in regards to the subject. As stated, I got involved with this with Dr. McLaughlin in 2009 when we published our work looking at the dental arena and how to control waste anesthetic gases. And one day our camera was still working, and as you can see here, this is showing the gas nitrous oxide here leaking from this delivery system, whereas in the other system the gases were minimized but still present. And that's the main objective here, is trying to minimize this exposure that was going on. One day the camera was working and none of the mask was on, and we thought that the gas would be gone, but it wasn't. So this led me to try to develop a product that would administer oxygen, knowing what goes on in the recovery room. And some of my anesthesia training from my residency days, trying to minimize exposure through a scavenger system that would allow oxygen to be delivered, that would not interfere with the workflow of the nurses, and still allow them to speed up the recovery of the patient. So the goals were to develop a product that would remove the WAG from the source, eliminate a lot of the WAG in the breathing zone, and decrease the cumulative effect, which Jim will talk about, make it compatible with workflow, still deliver oxygen, and not get that interrupted, and be able to monitor end-tidal CO2 if needed. So to prove that this system worked, we took the same protocol that we used in the dental operatory, using our infrared technology from Fluor Systems, a Moran unit with a certified industrial hygienist, and then Dr. McLaughlin to be the leader of a dual institutional review board study through Community Health Network and Purdue University. I'm going to let Jim now continue with this study protocol.
Thank you, John, very much. I appreciate the overview of the literature. I'm just going to quickly walk through the study that we did at Community Health. We had 19 patients. It was a pre-market version of the MASS study, but very close to what the product is today. The outcome of this particular study was not impacted by the particular data that was submitted to the Food and Drug Administration. And it was mentioned it was peer-reviewed and published in 2014. This is the PACU that we looked at Community Health. If I can just follow my arrow here, this is where the patients come in through these doors from surgery. This is our colleague Jerry Beanie from Fluor, who brought in his infrared camera. These are the patients then that fill each of the bays, and this gets filled up as the day goes on. So the study area was pretty much right over in this area right here, using the Fluor camera and the infrared spectrophotometer, which was the Moran Sapphire in this case. So one of the things that we looked at first, as I mentioned, the air changes in the PACU. As I mentioned, there are 6 air changes that are recommended with 2 fresh air supplies in that train. But one of the things that will impact on the movement of air in this environment is short-circuiting of the supply and the exhaust when you have the supply air here and the exhaust vent right next to it. So basically what you'll see is the air coming in, fresh air coming in, and being pulled right out through the exhaust air without circulating in the environment as it should. So one of the action items I like to give some of you listening in on the webinar today, when you go back to your work environments and you walk into a PACU, take a look at the ceiling. And you see if the air supply and exhaust are very close to each other, in this case right here about a foot apart, that they should be a minimum of at least 10 to 12 feet apart from each other to allow good air circulation. If that's the case, then contact your ventilation engineers and say, hey, I think we got an issue here that you need to address. So that's my action item for you today. As John mentioned, here's our Moran wand right here. This is where we quantified the data for the nitrous oxide and the sevoflurane coming in. This is our scavenging system in place right here over the patient, and the idea was measuring the waste anesthetic gases coming off from the patient at 6 inches and at 3 feet with and without this scavenging system. These are the data, and just I wanted to show you we captured this in real time, the quantitatively, and just show the variability in the exposures, the rises and the hills and the valleys and so on, and between the points right here. This is for patient 1, for example. The green is patient 2. What happened is that we were sampling, and as the patients were coming in, we'd be sampling one patient, then another patient would come in at the same time. We'd start sampling them. So you see some overlapping of patients coming in, but we sorted the data between patients so that we could identify the exposures for the nitrous as a SEVO. And of course, this is lunchtime over here where we don't see very low levels of exposure. But notice the very high exposures here from this particular patient, these other patients being brought in. So 2 things to pick up from this particular graph for each of the patients. One, this is our time element right here throughout the workday. These are exposures right here in parts per million. And notice that we're getting up 900 and 1,000 parts per million for some of these later patients right here. So a high degree of variability, number one. Number two, it does change with the patient over time, which is very important. But you never know what you're getting when you have a patient wheeled into the PACU in terms of what that exposure source might be. So this is without using the IsoGuard system. And this particular graph shows you with the IsoGuard system. Notice we still have some exposures here from individual patients, but the important thing is that the profile that you see here versus the previous slide is dramatically less. Keep in mind that as you read this article, we had twice as many patients on the day where we tested the IsoGuard system, and also we tested them over a longer period of time. So if we were to do apples with apples, we'd have really much lower concentrations overall with the IsoGuard system compared to not using it all. That's number one. And number two, recognize that we were only using the IsoGuard systems on the test patients coming in the first two cells of that environment that I showed you earlier. Had all of them had the IsoGuard system on, we believe that the levels, the ambient levels, would have been even lower. This just shows you the patients that we tested, and I want you to show you that relative to the NIOSH recommended exposure limits for nitrous, which is 25 parts per million, and is 2 parts per million for SIVO, that 60 to 70% over what the recommended limits are for every single patient that we're looking at across the board right here. Same thing with sevoflurane. However, when we looked with the IsoGuard system in place, we obviously had much, much lower exposures, but realized that some of these were probably as a result of the patient mask systems being put on and off and so on, tending to the patient. So does it control it to zero? No, but does it control it significantly? Yes, highly significant differences between using this system and not using this system. So one of the last two slides I wanted to show you right here is look at the cumulative dose that you get. Realize this would be a worst case scenario, being close to the patients, but by the end of the day, you're looking at some nurses being exposed to as much as 14,000 parts per million being in close proximity to the patient, and then over 1,000 parts per million you're looking at sevoflurane toward the end of the day. So the cumulative index for this is quite alarming. When you look at it with the use of the mask, is much less. So what I'm going to do is turn this over to Dr. Manning right now, who's going to show you some video vignettes of this visualization of the waste anesthetics and proof that what we are measuring is the gas and not anything else. Dr. Manning.
Thanks, Jim. If you look at this young lady, what we wanted to show is that if we brought a patient into the PACU before her surgery, to show the camera working, you see nothing coming out of her lungs as she's being asked what her name is, where she's from, what surgery she's going to have. The camera is to try to pick up the wavelength of nitrous oxide. That was what we had at that time to be able to try to see. Carbon dioxide is not part of that wavelength that the camera, the lens of the camera, is trying to zero in to be able to see. So we're just documenting here that you can't see anything. Now, when the patient then has her surgery and comes in, now what you're seeing here is the endotracheal is still in place, and you're seeing the nitrous oxide, which was mixed with sevoflurane on every single one of these patients, but we can't see SIVO with this particular lens. You're now able to see the nitrous coming out of the endotracheal tube. So this was part of the study protocol. This patient was brought in, and then you can see that the patient then has been extubated, and now you're watching the workflow. Now watch, this is the patient getting ready to take her first breath. She's obstructed, but watch how when she coughs, how much of this gas comes out of the lungs and into the breathing zone of all the caregivers who are trying to get the patient positioned. The mask is a mask that goes in place. This was now time 0. That's why sometimes in the readings there were certain parts per million readings, because the lungs are full of these gases. The mask has a vacuum system, which is right here, that goes into the wall canister, as well as an oxygen line that's going into the wall canister. What you see now is obviously a chin lift that the nurse is doing, but you're seeing the breathing zone once again that this nurse is directly overhead. Dr. Bagwell in their study showed that nurses, when they inhale air, are going to do it up to 12 inches away. So obviously it's fairly close proximity. Anything that's coming out of these lungs is going into her breathing zone. So if we then look at the next slide, now the patient is fairly comfortable. They're doing a little bit of what I guess some nurses call the PACU dance, where they're moving their arms and raising up. And as nurses, you're going to be moving the hands down, but the mask does stay in place. Let me move this here. The mask does stay in place without much problem. It's got a strap that just goes right behind the ears, just like a regular rebreathing mask that a patient would wear in some situations. But once again, you're showing the breathing zone with the patient and the nurse. And if the gas is removed, you're still going to see some of the gas that will come out of this area. And this was sometimes after 30 minutes, you'll see a dark halo that comes out of here. And these images can be seen much better if you go to the website called theinvisiblerisk.org. They don't show up quite as well on a webinar we're learning, but on the website, invisibleRisk.org, you can see different images of a cough, patient care, different things that may be of interest to you. And finally, once the patient is resting and ready for discharge, the mask is very tolerated by patients, and it does cut down on the different pathogens that are making people exposed. So I'll let Jim touch on some of the conclusions from the finding.
Thank you, John. I'm mindful of the time, so I'm just going to quickly highlight the findings, go into the conclusions. Dr. Manning wants to add a few talking points to the conclusions as well, and hopefully we'll have time for a few of your questions. One, obviously, we did this with IRB approval, which is important. So it was in a peer-reviewed publication, and it's being cited by several sources as we speak as an emerging issue, not only in PACUs across the United States, but around the world. We had most of the patients were brought into the PACUs, about a 40-minute time period where they were brought in and went through. As Dr. Manning said, the mask works very nicely with the workflow. It doesn't interfere with that and slow down the care of the patient. There were significantly lower exposures to the nitrous oxide and sevoflurane as a result of using the scavenging system. And finally, you can see all the details that's published in the JOPAN article last year. Our conclusions are that OSHA recommends exposure to waste anesthetic gas be minimized to the lowest practical level. This involves using the General Duty Clause 5A1 in the United States. Dr. Manning will expand on that in a minute. The patient is the main source of waste anesthetic gases in the PACU, as I stressed at the beginning of the presentation. The nurses may not be aware that they're being exposed directly, and as you saw, there's a lot of variability between patients in terms of exposures. They're in the breathing zone of the patients. It's certainly at the very beginning of the care process when they're wheeled in. And it's very important to note that our measurement of proximity, there 6 to 9 inches of that breathing zone, is very practical in terms of measuring the higher exposures, but at 3 feet, obviously very significant exposures as well, where the patients would be near the patient, the caregivers. And then, and just drop back right here. Dr. Manning, just wanted to say a couple final talking points, and then we'll wrap it up with our moderator.
Thank you, Jim. The development of anesthesia, as we've shown, is over 200 years old and is one of the greatest benefits to medicine and patient care. And as healthcare providers, we all would not want to have procedures done without anesthesia, but we want it to be safe, effective, and necessary control of these agents. Healthcare provider safety means scavenging gases in all environments, dental, OR, as well as the PACU. And all providers, whether you're a PACU nurse or a respiratory therapist, we all deserve a safe environment to do these procedures. As Jim pointed out, OSHA does have what's called the General Duty Clause, and that basically states that if we have a condition that exists in a workplace that may create a hazard, and we recognize this as a potential hazard, and the hazard can cause serious health consequences, and if there is a feasible means to control this hazard, then it's up to us to use it. And we feel that with the visualization and the measurements here and the history of exposure to waste anesthetic gases, we feel that Hopefully we're building something here that can help improve healthcare provider safety in a new environment. So I want to turn it back over to Jerry now, and thank you all for listening to Jim and I, and we'll try to entertain some questions here as much as we can.
Okay, Jerry, let's make sure you're not muted.
Thank you, doctors, for a wonderful presentation. It was thought-provoking and extremely informative. So thank you so much for your time. Martin, out in our audience, reminded me that all of you would probably like a reminder about the continuing education and accreditation process. And as I mentioned at the beginning of the hour, the webinar is approved for 1 contact hour for both nurses and respiratory therapists. And the important address that will have all the information for you is www.saxetesting.com/cf. Just complete the post-test and evaluation, submit, and you will be able to print your certificate for completion. I'll also remind you that there's a lot of other really interesting information on the topic at clinicalfoundations.org and theinvisibleRisk.org. And at this time, I'd like to pose some questions that have come from our audience for the good doctors. Tracy has said, are there any benefits/studies to provide PACU personnel with a different personal mask as opposed to the patient to decrease PACU exposure?
Let me try to field that one. This is Jim McLaughlin. There are systems out there. The problem is, charcoal systems and so on. They're just not practical if you're looking at wearing them all day long, 10 to 12 hours a day, that kind of thing. Compliance with it, I think, would just fall apart right away. There had been a long-standing issue with NIOSH and the CDC about surgical masks versus the N95s for pathogens and so on, and part of the problem was that using a better quality mask for the provider is helpful. The problem is compliance with it, the practicality of it, and so on, and also just the idea of controlling at the source. So by using a scavenging system at the source is going to be your best means of control. That's one. Number two, it assures compliance with the healthcare provider by not putting the burden on them to say, well, you weren't wearing your mask and therefore you were putting yourself at risk. So with all practical measures that you can apply out there, it's best to control at the source as they come in. I believe the IsoGuard system, as we tested it, is the best option that's available today.
Thank you. We have a question, excuse me, from Diana, who would like to know what you found in terms of how long after the patient enters the PACU is the patient still outgassing?
Let me take that one again if I can, and I'll let Dr. Manning chime in as well. I did the exposure assessment side of it. They off-gas the entire time. If you go to the article that we published in JOPAN, you'll see that the peak sources of exposure tended to be at the very beginning when they were wheeled into the PACU, and then tended to decrease toward that end. But we were still getting significant levels of waste anesthetic gases at the very end of their cycle in the PACU, above the NIOSH recommended exposure limits for both SIVO and for nitrous. But to quickly answer the question, it's that what's interesting, this is actually the perfect storm when you think about it. Here the patient is being wheeled into the PACU. They have the highest exposures that you're getting as a result of coming out of the operating room, but you have the healthcare personnel, the nurses, they jump right on the patients, if you will. I just love their attentiveness to the whole thing, but they're right there in the breathing zone, making sure that all the systems are checked, that their vitals are coming back, and so on. And it's because of those two things, that's when they're getting the peak exposures. And then when things settle down, when the levels are a little bit lower, there tends to be that less engagement there, but it's still a major issue all the way through. And our average cycle time for patients was about 45 minutes per patient, and we saw the gas the entire way through.
The only thing that I can add to that good question is that the gas levels will be related to parts per million reading. That goes back to the same old thing about percent. Different gases are given in different percentages. SIVO at 2% desflurane may be at a higher percent, but nitrous, if it's used, is going to be mixed at 50 to 70% with the other agents. So the higher the percent, we're starting to see that the longer it takes for that gas to go away. But all gases were still being measured above the recommended levels even 30 to 45 minutes after delivery to the PACU.
Thank you very much. Joanna has a question. She said, can you please briefly explain again why a dosimeter badge is not effective in accurately determining WAG exposure?
Oh, thank you for asking that question. It's actually a very, very good one, because a majority of environments tend to use dosimeters to monitor the environment. It is not a primary standard for measurement. It's a secondary standard for measurement for a lot of reasons. Part of it is, think about it, there's not an active pump that draws in the gas and has it absorb onto the membrane and then get itself fixed onto the membrane so that when it's desorbed and you can measure that concentration afterwards. So it is passive, so it's whatever air tends to be circulating around and gets on to the absorbent, which is the passive dosimeter. Then the idea of taking it, packaging it, sending off to the lab, all the issues that would come up with that in terms of some of the gases coming off of that media in that process. Sometimes it's if you measure something side by side, the passive dosimeters with something like an infrared spectrophotometer, they will sometimes be within a standard deviation of each other. But the difference is that when you ship that dosimeter off to a lab and you have a time lag, you have it going into the air, decompression, and so on and so forth, a whole host of factors come into play that basically says, you know what, it's great to have the dosimeter. It's really a screening tool. It's not a primary tool. And I think the reason people like to use it, it's easy to use. It's relatively inexpensive in terms of the analysis and so on. But you're really looking at something that may be giving you a false sense of security. The real gold standard is a machine that's going to measure in the parts per million right there at that time and not be subject to any of the conditions that you might have between the user taking it off and the time it gets analyzed.
Excuse me, doctor. Thank you for that answer. We have so many questions. Would you be opposed to going over by 5 minutes or so to answer some more of our audience's questions?
John and I both nodded. We'd be happy to.
Okay, excellent. Thank you for that. Well, let me mute my mic and let's keep asking questions. Thank you.
Great. I have the next one. This is from Dave. Why hasn't the government or NIOSH done more at this point?
Well, this is Jim. I'll take the front half of this, and Dr. Manning hopefully will take the back end on the clinical side. I'm on the research side. I think they need to be informed. I think part of this is catching them by surprise as much as it is the healthcare community about the PACU exposure issue. We are working very diligently now to contact NIOSH leadership, as they are the research agency that reports their findings to OSHA, to inform them of our findings and what we're doing. As I mentioned, if you go back and look at the literature, it was only recently recognized that the PACU may be an exposure issue for waste anesthetic gases, and of course our study really showed that not only is it an exposure problem, but we're seeing that in a host of other PACUs. That's number one. Number two is the sea change that's occurring in the increased use of SIVO, desflurane, and so on, and the decrease of nitrous in operating rooms that now makes it much more of a toxic hazard. And then finally, being able to visualize the exposures. We have technology that is really at the cutting edge to be able to not only show concentration, but actually visually demonstrate the exposures between the patient and the healthcare giver, and the nurses in this case in the PACU. And I think what we're working on right now is putting together a package. We're going to take it to Washington, D.C. We're going to show the NIOSH leadership that there's an issue right here, and we're going to strongly encourage them to get after this issue, because nothing matters more, obviously, than the health of the healthcare workers. They put their heart and soul in what they do, and it also impacts on patient safety. So it is a combination here that we're looking at in terms of outcomes, and we hope to do that actually within the next quarter.
Excellent, thank you. I had the. Oh, sorry, Dr. Manning, go ahead.
touch base one more time. From a clinician side of this, I think the main thing that I personally experienced was when I was able to visualize the nitrous when Jim and I were doing our research in our dental operatory. I was always trained that once the gas was turned off and the patient was spontaneously breathing and the percentages were down, the gas was gone. And I think the big thing that we learned through visualization as well as Moran studies is that percentages don't mean the gas is gone. And I think most anesthesiologists think that when this is at 0% and the patient is now breathing on their own, that most of the gas is gone. But through the visualization with the infrared technology, we're now able to see this as well as quantify it. And I think this is the main thing. The government has recommendations that have been looked at over and over and over again, and I think now that we can put some visualization as well as true measurements behind this, I think they will certainly look at things a little bit more thoroughly.
Thank you for the additional comments. Well, I've had the same sort of question from many people, so I'm going to sort of paraphrase it a bit, but I think it's interesting and may play into what you just said. We have 3 or 4 PACU nurses who have said they have tried to sell the concept of WAG scavenging in PACU to their hospital administrators or anesthesiologists, but the anesthesiologists have seemed to disregard the danger of WAG and PACU. Do you have any advice for how they could be more compelling in talking about it with administrators and anesthesiologists?
Sure. I think the things that I would encourage them to do is maybe if you can get a copy of some of the webinar slides here that have the literature review and the documentation about what's occurring and what's happening with parts per million and what molecular technology is telling us over the last few years. Number one, looking at the Smart Tot initiative and the fact that we really don't know the entire situation. We have animal models, we have non-primate models that are definitely showing cognitive and neurobehavioral changes secondary to anesthetic agents, primarily sevoflurane. Taking that documentation and the latest ASA news bulletin just in the last month had information in regards to the Smart Tot and what is going on there. And I think the visualization at the invisibleRisk.org, and I think those things, as well as then the NIOSH bulletin from 2007 and the OSHA general duty clause, I think those things are going to make it pretty hard to argue that we're not saying that these cause health problems. No one is trying to, that debate can go on forever and ever, and it's still going on with the Smart Tot initiative. The point is that scavenging systems are used in the OR in multiple ways in dentistry, and they just need to be used in the PACU to minimize risk.
Can I just make a couple of comments from the scientist side of the equation and working with anesthesiologists? I have the highest regard for the profession and what they do, but it's also a matter of their perspective. Think about it. They are in command and control in terms of administering the anesthetic gases to the patient. They have monitoring schemes to tell them changes in blood pressure, respiratory rates, and everything that they do, and they have immediate feedback on everything that they're doing to control the patient. So their training and focus is obviously on what they do, and that is taking care of the patient. My training and focus is on the health caregivers, the nurses, and those that take care of the patients. And we're dealing with, again, parts per million, where they're dealing with percentages. And if the anesthesiologist had the same kind of control over monitoring what impacts the nurses as they would the patients, I think many would come around and say, wow, look at what's happening to some of the more subtle exposures with DNA. What's happening in terms of judgment errors that may occur as a result of the exposure to the waste anesthetic gases, the fatigue that comes in, the headaches. Many of the symptoms that I know that people listening to this webinar, the nurses, have experienced in the PACU, and saying, well, is that me or is that something else? The key is, you've got this golden triangle right now. It is a recognized health hazard, waste anesthetic gas. Number two, we have measured it in significant quantities in the PACU. And number three, there is a cost-effective means of control that significantly reduces those levels. That golden triangle points back to the 5A1 General Duty Clause of saying employers are to provide a safe and healthful workplace for their employees. Without one of those corners being in play, then it's a much more hard scrabble way of trying to make the case. We're making the case that we believe that while the anesthesiologists have their position in command and control with patients, we have our position in terms of command and control for the healthcare personnel, not only for their benefit, but also for patient safety.
Thank you. And as one final question, I think you touched a bit on it when you were talking about some of the potential impact on judgment and attentiveness in PACU based on WAG exposure. Marie says, sadly, I feel like in order to get more support for the product to be used at our hospital, we need to make it more about patient safety. Comments on that?
Well, I think once again it's another great question, and the only feedback we can give you is that I think in one of the studies I talked on earlier in MUSAC pointed out that nurses were one of the groups that had the greatest risk due to the fact that they are being exposed at a longer level with higher concentrations. They're in the PACU, they're there for 8 to 10 hours all day long, and their exposure risk is much different than what's going on in the OR. And with the research that Jim talked about in regards to headaches and fatigue, the longer your exposure rate is, the more that creeps into the formula. And we all, I think the airline industry has worked closely with medicine to look at what happens with fatigue and how errors can increase. And anything we can do to decrease fatigue as a healthcare provider will hopefully minimize patient problems and improve patient safety.
Thank you so much to both of you. We appreciate your time. And once again, the address to obtain your continuing education credits is www.saxetesting.com/CF. Thank you for joining us. Doctors, any final comments?
Thank you for the opportunity to address those attending the webinar. Just realize when you saw my disclosures, I've been in the business for a long time. My passion is really taking care of the healthcare workers. Nobody does it better than you. Let us give you the opportunity to take care of yourselves so that you can continue to do the great job that you do out there in the healthcare community.
Well, thank you both Doctors Jim and Dr. John and Jerry as well. We did go over today, but we had so many questions and hundreds of people still on the line that it was pretty important to try to answer as many of them as we can. I'd like to thank each and every one of you, our guests in the audience today, for your time and your very thoughtful attention. Thanks again, everybody, and bye for now.